Today we're going to talk about contact dermatitis, an inflammatory skin reaction that occurs when the skin comes into contact with certain substances. There are two main types of contact dermatitis: irritant and allergic. Irritant contact dermatitis is the most common, accounting for about 80% of cases. It's not immune-mediated. Instead, it results from direct chemical or physical damage to the skin. Think of repeated exposure to soaps, detergents, or solvents. Allergic contact dermatitis is different. It's a delayed type IV hypersensitivity reaction that involves T-cell activation after contact with an allergen. Metals, cosmetics, and certain plants are common culprits. Let's look at the pathophysiology. In irritant contact dermatitis, epidermal cells release inflammatory mediators in response to direct damage. In allergic contact dermatitis, the immune system requires a sensitization period, usually 10 to 14 days before reacting. Once sensitized, subsequent exposures trigger vasodilation, inflammation, and that characteristic rash. Now for the clinical manifestations. In acute contact dermatitis, symptoms include itching, burning, redness, vesicles, and even bullae with oozing. These reactions are usually limited to the site of contact. In chronic contact dermatitis, we see scaling, thickened skin, lichenification, and pigment changes. Constant scratching or rubbing can cause abrasions, and secondary bacterial infection may occur. Systemic symptoms are rare unless the dermatitis is widespread. Moving on to assessment and diagnosis. The key is a thorough history and physical exam. We ask when the rash started, whether it relates to work or products like soaps, cosmetics, or metals, and where the lesions appear. Allergic contact dermatitis is often confirmed with patch testing, which exposes the skin to specific allergens to see if a reaction develops. The true test is a common method, and an extended North American screening panel may increase sensitivity. In irritant dermatitis, patch testing is negative, which helps distinguish between the two types. Let's compare the two in more detail. Allergic contact dermatitis results from skin contact with an allergen after a sensitization period. It often appears on the dorsal aspects of the hands. On a microscopic level, we see vasodilation, perivascular infiltrates, and intracellular edema. Diagnosis relies on patch testing, which is contraindicated during acute, widespread dermatitis. Treatment begins with avoiding the offending material. For mild cases, topical corticosteroids and cool compresses with aluminum acetate or Bureau's solution help reduce inflammation. More severe cases may require a short course of systemic corticosteroids, like prednisone, usually for 7 to 10 days. Oral antihistamines are also helpful for controlling itching. Irritant contact dermatitis develops when the skin is damaged by a chemical or physical irritant. It can occur after a single strong exposure or after repeated contact with milder irritants. The most common sites are the hands and lower arms. Clinical features include dryness lasting days to months, vesicles, fissures, and cracks. Patch testing is negative, confirming it is not allergic. Treatment involves identifying and removing the irritant. Hydrophilic creams or petrolatum help soothe and protect the skin barrier. Topical corticosteroids and compresses are used for weeping lesions. If infection occurs, antibiotics may be prescribed. Oral antihistamines can also help with pruritus. The nurse's role is crucial in assessment, education, and prevention. Patients need to understand what triggers their dermatitis, how to avoid irritants and allergens, and how to apply their treatments correctly. Education should include strategies for protecting the skin, such as wearing gloves, using emollients, and avoiding harsh soaps. To summarize, contact dermatitis can be irritant or allergic. Irritant dermatitis comes from direct damage to the skin and is much more common. Allergic dermatitis is an immune-mediated delayed hypersensitivity reaction. Both can cause significant discomfort, but with good assessment, patient education, and proper management, including avoidance, topical therapy, and sometimes systemic treatment, patients can control their symptoms and protect their skin health. That wraps up today's lecture on contact dermatitis.